Varn Burton, President and CEO of the American Kidney Fund. And on behalf of all of us at AKF, welcome to Kidney Action Week. We're so glad that you're here, and we hope that this week will leave you informed and inspired to take charge of your health. It's a totally virtual event, so whether it's from your home, while you're on dialysis, or even vacation, we're excited to have you join with the kidney community for Kidney Action Week. Our goal is that you will take away insights that you can use in the fight against kidney disease. We would like to thank our sponsors for making this week possible. First, our lead sponsors of Kidney Action Week, Boehringer Ingelheim and Otsuka America Pharmaceutical Incorporated. We would also like to thank our session sponsors, AstraZeneca, GSK, and Horizon Therapeutics PLC. This year marks the 50th anniversary for the American Kidney Fund. We were founded in 1971 to help just one person who couldn't afford dialysis. And while our mission and programs have expanded immensely since then, we have never lost sight that everything we do is rooted in helping people fight for their lives. Everyone knows someone with kidney disease. It affects 1 in 7 Americans. But most people who have kidney disease don't know that they have it. Working together in education and awareness collectively, we can pave the way for everyone to have a longer and healthier life. And that's why we started Kidney Action Week. We're looking forward to a full schedule of events focusing on all things kidney: prevention, disease management, dialysis, transplantation, nutrition, and other kidney health topics. We're bringing together top nephrologists, dietitians, patients, caregivers, and others to provide tools and resources and education that you can use. On Wednesday, we will also have a special AKF congressional briefing focused on eliminating racial and ethnic disparities in kidney transplantation. AKF is so proud to be a strong and independent voice advocating for policies and practices that improve access to and quality of healthcare for people with kidney disease. And we're so grateful to our more than 16,000 patient advocates who are educating state and federal lawmakers about the disease. Finally, we are so grateful to you, our community. With your partnership and support, we're fighting kidney disease on all fronts. It wouldn't be possible without the support we receive from people like you. And we invest 97 cents of every dollar that you donate to our program, not to our overhead. Kidney Action Week presents us with the opportunity to continue the fight along with all of you and working to make a world without kidney disease. Please invite your friends and family to join us and help us spread the word that it's time to join the conversation and learn more about the fight against kidney disease.
Good morning, everyone. My name is Mike Spigler, and I am the Vice President of Patient Services and Kidney Disease Education at the American Kidney Fund. I want to thank you for joining us for AKF's Kidney Action Week. We are so excited to share this week's sessions and speakers with you. Our goal for Kidney Action Week is to bring you information for wherever you are in your kidney journey, from being at risk from diabetes and high blood pressure to early stages of chronic kidney disease and transplant, and everywhere in between. Throughout the week, you'll get the chance to ask questions of experts in the field and inspiring patients just like you. And we are starting off today's Kidney Action Week sessions with a topic you might not be very aware of, which is kidney disease of unknown cause. As you'll see in a moment, AKF has good reason for having an interest in this area, and we've brought together the kidney disease and rare disease communities this past December to address it. Our ultimate goal through the Unknown Causes of Kidney Disease Project is to get every patient a definitive diagnosis of what caused their kidney disease. This is a tough task, but we are fortunate to have built a wonderful group of collaborating organizations to help us, including our generous supporters of this project. So before I go any further, I'd like to thank those sponsors. Bring up our sponsor slide, thank you. First, our champion sponsors, Alexion, Otsuka America Pharmaceutical, and Travere. And next up is one of our two leadership sponsors, Natera. And here to represent Natera and talk about why they are supporting this project is Trudy McKanna. Trudy?
Thanks, Mike. It's a real pleasure to be here today. My name is Trudy McKanna, and I'm the Director of Medical Education at Natera's Organ Health Division. I'm also a clinical genetic counselor for about 15 years before I joined Natera, which is a world leader in DNA testing and technology. I think if there's one thing that Natera understands with its history of genetic testing and with all of its genetic counselors on staff is really the burden of unknown etiology for disease and the burden on families, the burden on healthcare providers, and the drive to progress that, the need to get a diagnosis and the possibilities that are inherent in that. We were really excited to learn that the AKF was also interested in promoting more understanding of unknown etiology for kidney disease, because we feel like there is a real benefit to exploring this process. In fact, Natera, when we realized the unmet need for accessible genetic testing with access to genetic resources, we launched a comprehensive genetic panel called Renasight in 2020 to help address some of these needs. And we've really learned a lot from our healthcare providers and our patients about this problem and some of the ways that we can help address it. We are really excited to be working with AKF, to be part of the summit last year, and to continue to work with them specifically on the areas of provider and patient education about genetic testing, about unknown etiology for disease, because we really believe that this type of initiative, this type of action will improve patient access to care and outcomes for patients who have unknown etiology for their kidney disease. So once again, Mike and team AKF, thank you so much for inviting us to be here today.
Thank you so much, Trudy. Our second leadership sponsor of this project is Vertex, and here to represent Vertex is Dr. Ogo Egbuna. Ogo, why is this project important to Vertex?
Yes, thank you, Michael. Hello, everyone. My name is Ogo Egbuna, and I'm the clinical development lead for kidney programs here at Vertex, where we focus on developing precision medicines targeted at the underlying causes of kidney disease. This meeting is an important step in advancing care for patients because the time has come for us as a community of patients and healthcare providers to leverage the powerful tools available with genomics to more precisely identify the causes of disease that too frequently are either misdiagnosed or not diagnosed at all. This working group organized by the American Kidney Fund will be valuable in getting people working together on the right issues to get us to our vision. And this vision I hope we can arrive at is in three parts. First, a future state where healthcare providers can more confidently and more frequently tell patients and their families what exactly is wrong. Secondly, a situation where we can provide more precise prognosis for patients. And thirdly, be able to direct patients to the right trials and/or initiate the right treatments that can have safe and effective impact on the outcome of their disease. So special thanks to the American Kidney Fund for the opportunity to support and be part of this important effort. And I encourage us all to actively participate because patients and their families are waiting. Thank you.
Thank you so much, Ogo. And finally, I'd like to thank our title sponsor, Sanofi Genzyme, and their representative, Dr. Manish Maski, who will be joining our panel to discuss a little bit later today. But I want to give Manish an opportunity right now to tell us why this project is important to Sanofi Genzyme.
Thank you, Mike, and good morning, everyone. First off, special thanks to the American Kidney Fund for this amazing opportunity. My name is Manish Maski. I am the Global Medical Head for Rare Nephrology at Sanofi Genzyme. Rare nephrology just means genetic nephrology. And we have a long legacy in this area, starting with a disease called Fabry disease, and now developing into other areas of high unmet need for patients and their families, including Alport syndrome and a few other things in early development. I am also a still practicing nephrologist when there's time in Boston area. I think that this initiative is of real importance to patients and their families. As the previous folks have mentioned, patients are on the diagnostic odyssey for far too long. And that results in suboptimal outcomes for them. And in general, it's not good medicine. So using the tools that exist now that are readily available, and the resources that are now the part of most healthcare systems to get patients off of their diagnostic odyssey and confirm a diagnosis is really the first step to setting up their overall care plan, and we're really delighted to be a part of that. Thanks, Mike.
Thank you very much, Manish, and we'll bring you back on in just a bit with the rest of our panelists, but thank you very much and thanks for the support. All right, so let's bring up our slides and let's talk to you a little bit about the unknown causes of kidney disease. So a kidney disease of unknown cause is one that officially has been designated by a healthcare provider because no clear cause can or has been determined in the course of treatment. The graph you see on the screen right now shows the breakdown of kidney failure causes in the United States. And as you can see, the two main causes, which probably many of you probably already know or maybe have experienced, are diabetes, which is the teal color on this graph, and high blood pressure, which is the lime green color. And there are a mixture of other types, and then the unknown, which you can see here, makes up about 5%. That's the dark blue up in the top left corner. That on its own was striking enough for us at the American Kidney Fund to take notice. But if you look at the data that we collect, you'll see why it soon became even more important. Next slide, please. So first, let me tell you a little bit about the data that we collect. Through our financial assistance program, AKF maintains one of the largest databases of patients with kidney failure in the United States. Our assistance helps 1 in every 6 dialysis patients. It is primarily made up of people from communities of color. And one of the things that I'm the most proud of here at AKF, and I think all of us are, is that more than 100 patients, actually about 110 patients now, every month that we assist, receive a kidney transplant. So we also have some transplant data in this database as well, and it's growing by the day. In 2018, we upgraded that system to improve our user experience and track patient outcomes. And one of those things that we tracked was what caused their kidney failure. Next slide. So in looking at this slide, you can see for the most part, everything else was similar to the national data, except for unknown causes. In our database, primarily made up of patients who are struggling financially, the percentage of patients with an unknown cause was 14%. That is nearly triple the national average. And we wanted to find out why, and we wanted to do something about it. Next slide. So last year, we launched the Unknown Causes of Kidney Disease project. And the project, as our initial speakers mentioned, really culminated with a summit that was held on December the 1st of the leading researchers, advocacy organizations, rare disease groups, industry, government agencies, and most importantly, affected patients to create a roadmap forward. And this roadmap highlighted the barriers to change and offered solutions. It was published on July 26th of this year, and you can actually free to download it right now. And you can find it at kidneyfund.org/UCKD, and certainly encourage everyone here to download that and take a look. Next slide. So we are already working with our partners across the healthcare and rare disease space to now put solutions into place. But today we wanted to talk about some of the common barriers that are highlighted in the roadmap and give you some tips on how to overcome them. So here are just some of the ones that were identified, the main ones in this project. First are patients getting a late diagnosis of kidney disease. So all of you here probably know that all too well. A mindset from the healthcare team and physicians that diagnosis of the cause may not actually change treatment, and that may or may not be true in some cases, but it certainly isn't something that we think should just be completely discounted and kind of washed over. A lack of adequate insurance coverage, something we're very familiar with here at the American Kidney Fund, especially in relation to genetic testing, especially in things like Medicare and Medicaid. A lack of awareness and perhaps well-established evidence-based info to guide genetic testing. So when and how should someone get a genetic test? What happens after that happens? On trying to figure through that out for patients. And communication barriers between patients and healthcare professionals about kidney disease in general. So those are the barriers. We certainly have solutions in the roadmap as well. But today we really want to talk about the barriers and what you can do right now to put in place things to try to overcome them if you're experiencing this yourself or a loved one is. So now I'd like to bring in the rest of our panel and introduce them to you. First is Dr. Delphine Tuot. Delphine is an associate professor of medicine in UCSF's Division of Nephrology at Zuckerberg San Francisco General Hospital and Trauma Center. Next is Jack Johnson. Jack is co-founder and executive director of the Fabry Support and Information Group. And finally, bringing back in Dr. Manish Maski, who is the global medical head for rare nephrology at Sanofi Genzyme. So again, thank you all for joining me here again today. So a reminder, if you're watching live, you can type in your questions both in the Facebook feed or in the Q&A feature, and we'll try to get to as many questions as we can. We have plenty of time to do that today. I want to thank you all for joining our conversation. But I want to open it up to our panel discussion and talk about some of the key takeaways that we had on the barrier slide from the roadmap, and maybe give some advice for patients out there who are still trying to find answers. So Delphine, why don't I start with you? One of the barriers described in the roadmap is that patients are not getting diagnosed with kidney disease of any kind, regardless of the cause, early enough. Why is that, and what do you recommend for patients out there who have family members at risk? How can they get an earlier diagnosis of kidney disease?
Yeah, thank you. First of all, thank you for inviting me. It's a pleasure to be part of this panel, and good morning to everybody. I agree. I think most individuals do not get diagnosed with kidney disease early enough. The reasons are multifactorial. I call it a string or a Swiss cheese kind of model, I think. First off, kidney disease is largely asymptomatic until the very end stages, which is both a blessing and a curse because individuals and providers don't tend to think about it early enough. I think when providers, primary care clinicians in particular, do think about kidney disease, they often only check blood tests to detect kidney disease and don't often check a urine test. And so I think one of the things that we as in the nephrology community are really trying to educate both individuals, the lay public, and primary care clinicians is the importance of checking urine for protein to detect kidney disease. And then I will say among the individuals whose providers have checked both blood and urine testing, I think providers don't feel comfortable talking about kidney disease. There's a lack of uniform language on about how to describe kidney disease and what to do next. And really that's where there's suboptimal, I think, communication between primary care clinicians and nephrologists or specialty care. And so I think there's action and there's activities along all components of that spectrum to try to fix some of those barriers that exist.
Thanks, Delphine. And just thinking about the urine test, is that something that can be done at a routine office visit? But how does that test happen?
Yeah, thanks for asking. It is a very simple test. It's just a spot urine test. You can give any patient, any individual can just give a little bit of urine. It's fairly cheap, easy to do, and it can detect at least 25 to 30% of kidney disease that otherwise has normal blood testing. So again, super important. And we also know that urine testing detects kidney disease, particularly among communities of color, which is also of particular importance.
Right, and that's, with our database that we see, that's a huge part of the make of our database, our communities of color too. And again, one of the reasons why this is such an important piece for us and for the community to try to solve that problem.
Exactly.
Right.
And so early, the hope would be then earlier detection would then allow for better understanding of what is the cause of the kidney disease, hence a lot of the discussion we're having today.
Great. Thanks, Delphine. And again, please feel free to send in questions as we're going through, just to get some time to get some first questions in, but please feel free to send those in via the Facebook live stream or the chat box here in the conference system. Jack, I'm going to turn to you. One of the things that were found in the barrier there was the mindset that a diagnosis may not change treatment. And it's something I've certainly heard physicians say to me directly. How does that play into Fabry disease? What are some of the benefits for patients of an unknown cause of kidney disease and getting an answer?
Yes, and thank you very much to the organizers for inviting me. With Fabry disease and other rare diseases that may have implications for kidney failure, it's very important to have that official diagnosis, that really knowing what is going on, because it can make a huge difference on treatment. Yes, many nephrologists are very educated on what conditions cause kidney failure, but they can't know all of the rare diseases. And many in your medical team may have never heard of Fabry disease or some of the other rare diseases, if that happens to be the case. So just because you have kidney failure doesn't mean other things are not happening at the same time. And this is especially important with Fabry. It can affect the heart, it can affect the central nervous system, the GI, you name it. Kind of Fabry can hit in quite a number of areas. Also, there are, getting treatment is available today for Fabry disease. We're so fortunate in that. And there are many companies that are very interested in Fabry disease today. So there are clinical trials happening with a number of approaches for treating this. And the same is true with other rare diseases. Managing symptoms is so important because, getting that treatment, taking care of your kidney, you've also got other things happening as well. So you have to take care of the symptoms. It's not just the kidney medications or kidney transplant. It can also be other things that a single treatment or sometimes multiple approaches may be needed to give you the best protection and the best for your health. Likewise, it's important to be able to speak with your family. So being as educated about these Fabry and other rare conditions as possible is vital, so that you may have other family members at risk and you don't want them to have to experience many of the same things. So that's very important. Also, it'll help you educate your medical team that is not familiar with Fabry disease. And then again, you want to make sure to be involved, not only in your care, but also be involved in the patient communities that exist out there, the rare disease organizations, so that you're not alone. There are many others going through some of the same things. You may be able to share advice from your journey, and you may be able to find important information from the journey of others.
Thank you so much, Jack. Thank you so much, Jack. And I think one of the things you touched on is just the available treatments now, and it's not just for Fabry. I mean, there are so many which were rare diseases. I've been in the field of nephrology, I guess, all in about a dozen years now, and when I first started here, it was hearing calls from patients who there just was nothing, not even a trial, let alone treatment now, and whether it's PKD or Fabry or PH1, I mean, there are many, many treatments now, and if it's something that you have or you have in your family and you may have been worried about talking now, I mean, there are some innovations out there, and I certainly would recommend visiting our website, kidneyfund.org, going to that rare disease and try to get more information on that. And this is a pretty good segue for a question I want to ask you, Manish. You're at a company that has some large successes in finding treatments for rare diseases. How important is it for patients to get a diagnosis in regard to future therapies?
So, without question, a diagnosis is the entry point into, so many things regarding a patient's medical care. But before I kind of expand on that, I just want to mention how it's just as important from a psychological standpoint for a patient to finally achieve a diagnosis for his or her kidney disease. And Fabry is a perfect example. A lot of these men and women go for 10 years or more with a variety of symptoms that people don't put together as being related to that disease, and they don't get tested, and perhaps progressive organ damage is occurring, all while the patient is getting bounced around to multiple specialists and so forth. So there is great power in a diagnosis for the patient, and it empowers them. Now, if it's their entry point into the medical system, as you mentioned, Mike, nephrology is undergoing somewhat of a renaissance right now. In the 14, 15 years that I've been in the field, there were previously very few trials, very few available options, just sort of general management to protect kidney function for as long as possible. But now, our company, but many other companies are very interested in developing specific therapies for specific diseases. And I can't remember another time where there were so many trials of so many different compounds for a variety of kidney diseases. So a diagnosis allows a patient to either get on a therapy that's perhaps already approved, but also to participate in clinical trials for these several therapies that are currently in development. It also allows us to learn more about the disease. Once we know, that someone has a rare disease or a less common kidney disease, there's power in numbers. So, aggregating these patients, studying them in a registry, et cetera, allows us to better understand the disease for the development of new targets for therapy.
Thank you very much. Thanks, Manish. Delphine, a question for you. You had mentioned talking about some of the, I guess maybe the bridging the gap in knowledge between provider and patient, and a big part of that is health literacy, but it's also a power dynamic there. And I certainly have talked to patients, and I'm sure Jack probably has as well, where they feel like they're going in and their doctor's not listening to them, or they don't really trust what they may have found online. What advice do you have for patients when starting this conversation with their doctor?
Yeah, thank you for asking. It's such an important topic. I recommend that individuals write down, come to your doctor's office prepared. Write down all of your questions. Think about it the couple days before you go, the week before you go. Keep a list either next to your bed or next to your toothbrush in the morning, or wherever is comfortable for you, where you can just jot down some questions when you think about them during the week, and bring them to your doctor's office, and feel free to ask every single one. I think oftentimes in the moment, there's anxiety in the moment. You forget what questions you had written down or you had a day or two ago. If they're written down, you're much more likely to remember to ask them. I think similarly, it's helpful to bring a loved one with you to try to keep you on track and remember, oh, didn't you have questions that you wrote down for Dr. Tuot or so on? And I think, so I encourage all of my patients, I encourage my family members to go to their doctor's office with another family member, another friend, or another loved one. I think it's always helpful to have somebody else that's trusted in the doctor's office with you. And I think additionally, it is never wrong to ask just, how are my kidneys doing? Do I have kidney disease? Two very simple, open-ended questions that will then hopefully initiate a conversation about whether, oh, have I been tested for kidney disease? Have I gotten all of the tests appropriate? And then what did the tests show? And ask about, what did they show? Do I have kidney disease? How can I find out more about it? So I think those types of conversations about kidney disease can be particularly helpful. I think related to this topic and kidney disease of unknown etiology, I think as was mentioned earlier by some of our panelists, is that if you can also jot down all your symptoms that you may be feeling, regardless of whether you think they're associated with the kidney. Many of the rare diseases are multi-organ and systemic, so they affect not just the kidney, but do affect other parts of the body. And so if you can provide a list of all of the symptoms that you've been feeling, that can sometimes help your providers put two and two together and think more broadly about systemic diseases, which may be also affecting your kidney.
Fabulous. Thank you very much, Delphine. And we do have a question that has come in that I'm going to pose to Manish in a minute, but please, a reminder, if you are watching either on Facebook or through the conference platform. Continue to send in your questions. We've got a team fielding those and sending them over to me, so we will get as many of them answered as we can. We did have a question regarding the tests for Fabry disease and how you could find that out. I would encourage you, I know we are posting some resources as well, but if you go to the kidneyfund.org website, you can find lots of information on Fabry particularly. A question, I guess, for Manish and really for the entire panel, and what are some of the other tests and assessments just generally that could be done to help a patient possibly get an answer to the cause of the kidney disease? Delphine, you talked about blood and urine tests, but Manish, why don't I start with you? What are some of the other tests and assessments that you might recommend for someone that's looking for answers?
Yeah, so I think that nearly all patients diagnosed with chronic kidney disease should undergo some form of imaging of their kidneys. The most common initial imaging test is an ultrasound of the kidneys. And, this has no radiation associated with it. It's non-invasive. It's widely available in a variety of healthcare settings, and it's quite accurate in giving a good assessment of kidney size, kidney structure, the presence or absence of cysts, kidney stones, developmental abnormalities. You almost always learn something from taking a picture of the kidneys, and often that's with an ultrasound. I think next, once sort of structural or congenital sort of disease has been ruled out by a kidney ultrasound, probably the two most common things are the simultaneous blood and urine tests. So blood to look for some specific markers. The most commonly used is creatinine. Creatinine is a waste product that's produced by all of our muscles and cleared out of the body by the kidneys, and it should be kept within a tight range unless you have kidney impairment, in which case it'll build up in the blood. So that's usually how patients are caught as having chronic kidney disease. But the urine tests are extremely important, as Delphine mentioned. Then what are the things that are tested? So blood, the presence or absence of blood, inflammatory cells, protein. Those things all can help guide the clinician toward a diagnosis. And I would say that if despite a series of blood and urine tests along with some companion imaging, if those are unrevealing, many patients will get a kidney biopsy, and what that means is a simple procedure, usually under the guidance of ultrasound or something, so that the person taking the biopsy can get a very precise couple small pieces of tissue using a needle that goes right over the back. It's generally an outpatient procedure, and looking at the kidney tissue under the microscope and doing a variety of tests on the tissue often, but not always, leads to a kidney the disease diagnosis. So why did I say often but not always? There are several diseases that result in scarring of the kidney filters and the kidney tissue, and that's sort of kind of the final common pathway of kidney injury. And if the horse is out of the barn, so to speak, and you just get scarred down kidney tissue in the biopsy, you still really haven't made a diagnosis. That's where genetic testing can be really powerful, and the literature is full of examples of unrevealing kidney biopsies or kidney biopsies leading to an incorrect diagnosis that was actually changed upon genetic testing. So classic example is Alport syndrome. That's frequently just seen, depending on the stage of the disease, as scarring of the kidney tissue, which could be from many things. But then when the patient gets genetic testing for the genes related to Alport syndrome, that makes the diagnosis and opens up a whole new sort of world in terms of the patient's prognosis and potential clinical trials they can participate in.
Thanks, Manish. I appreciate that. And Jack, I'll bring a question to you for genetic tests in just a second, but we actually did get a question related to kidney biopsy that I think I'll pose to Delphine, if you don't mind taking it. So my doctor recommended that I get a biopsy to see if they can figure out what's wrong with my kidneys. Won't that damage them further? So what are the risks of biopsy, if any, that you could maybe talk about?
Yeah, absolutely. I will first off say that kidney biopsies sound very scary. They're actually very routine and very safe. They're done, as Manish mentioned, in the outpatient setting, so you don't usually need to be hospitalized. Some centers like to keep you overnight just for monitoring. The main risks of a kidney biopsy are bleeding. Because the kidney has so many small blood vessels. We are able to avoid the big blood vessels by doing the biopsy under imaging, so under ultrasound or under CT, depending on your center. But a little bit of bleeding is not uncommon, and that's what we like to monitor for afterwards. The fact is that we do several little biopsies with each kidney biopsy. Essentially, we do 2 little or 3 little cores, which is not very much tissue. It's sufficient such that we can hopefully make a diagnosis with our pathology colleagues, but it's actually not enough to cause any scarring or any damage. So usually the benefits of the biopsy or potential benefits of a diagnosis outweigh any possible risks, namely the risks of bleeding. But it is important. Yeah, I'll just say, but it is important to talk and ask about those risks and benefits anytime a provider or a clinician recommends it. Chances are that if your clinician recommended a biopsy, he or she has already sort of thought through the risks and the benefits, but perhaps hasn't communicated it well enough to you. So definitely ask.
Great, thank you. So Jack, I'm gonna come back to the genetic test question. So what advice do you have for patients? What does your organization recommend about genetic tests? What do they need to be aware of? And are there any risks for finding a genetic marker in the results?
Sure. So for instance, just with Fabry, the testing for genetic testing is mandatory to get an accurate diagnosis for females. With males, usually an enzyme assay, just a blood test, can indicate whether Fabry is the cause or not. And then genetic testing is usually followed up with that to find the specific mutation, which can be very important. There are so many different ones in Fabry, and they can kind of spell out potentially some of the other impacts of the disease. Things to be aware of is that not all insurance covers the cost of genetic testing, and Medicare and Medicaid usually do not pay for any genetic testing either. Fortunately, there are free testing programs that exist out there, and we're happy to direct anybody to the centers and the appropriate people to be able to obtain those testing programs. Also, for the question of risks, yeah, there can be the potential for some discrimination, although the GINA law should help prevent against that. With life insurance, this in particular can be an issue when it comes to life insurance, disability insurance as well, long-term care insurance. All of those can have an impact. One of the things we suggest is if a child, for instance, is diagnosed, or a very young person, and adults too, there are various companies that do offer no exam needed, no questions. You automatically qualify for certain insurance. So it's always a good idea to look into those possibilities as well. And if you already have insurance, you can ask to find out information about your particular policy. So, yeah.
Thanks, Jack. I appreciate that. And it's definitely something that the American Kidney Fund is looking at and taking seriously the risk of that kind of discrimination in insurances, and certainly something we're seeing with living donors too. And we can always use your help. If you're out there and you're not part of our ambassador network right now, please go to the kidneyfund.org website, find out how to do that, because we certainly could use your help both nationally and at the state level. as well. All right, so we are going to move into just taking, I think, your questions directly. So let me just take a look here of what we've received thus far. Just a question as far as maybe Delphine, I'm going to pose this one to you. You know, if you have a family member with kidney disease, just generally, what is your own risk? I mean, from any cause of getting kidney disease yourself, and what should they do as a precautionary measure?
Yeah, that's a little hard to answer, but we do know that that kidney disease does run in families. And so if you have a family member who has kidney disease of any cause, your risk of having kidney disease is slightly higher than otherwise. That could be because of genetic reasons. That could also be because of environmental reasons or living in similar conditions that may have exacerbated or caused the kidney disease of your family member or loved one. So I think if there's anybody in your family with kidney disease, I do think it's important to ask for you to be tested. And again, this is where I think ask your primary care clinician, and you can say, you know, my cousin has kidney disease, my sibling, my parent, et cetera. What are my risks, and can I be tested for kidney disease? And please remember that that should include a blood test and a urine test. And I think, again, that can be the starting point. If there is an abnormality in either one of those, then you can continue on and discuss what are the next types of blood tests, the imaging, so on and so forth that Manish had talked about previously.
Thank you so much, Delphine. Jack, a question for you. When, in your opinion, I mean, obviously it's certainly dependent on you know, a case-by-case basis, but are there certain things then that are showing up, or conversations that you recommend either through your own experiences or the patients that you work with, on when someone should seek a second opinion?
Certainly. You know, as was talked about earlier, it's very important to keep those questions at hand. So write those down, take them with you. But whenever you don't feel completely comfortable, or it's a good idea potentially to get a second opinion, if your first opinion didn't seem to address all of the issues that are going on, didn't get a real diagnosis, certainly having a second opinion is a good idea. And we would encourage individuals to do that for your own health.
Delphine, Manish, you guys are both practicing nephrologists. I mean, what's your opinion on second opinions, and how do you do that when that's kind of brought up in your own kind of, with your own patient body you have? Manish, why don't I start with you, maybe?
No, please, Delphine, please.
Okay.
I was just going to say, I wholeheartedly agree with Jack. I think if you don't feel comfortable with the discussion you've had with your clinician, and you don't feel like you've gotten the answers that you need, you are very well entitled and recommended to ask for a second opinion. I've had some of my patients say, you know, I'd like a second opinion just to make sure that we're all on the same page. I completely am fine with that, and I think that is appropriate. Sometimes it's about sometimes there won't be any new information divulged in the second opinion, but you can feel more confident that two different clinicians have arrived at the same decision or the same recommendation for you. And sometimes you'll find a better rapport or better communication, or you'll get along with another provider better. So I think a second opinion is never wrong.
Great. Manish, anything that you want to add to that?
Yeah, just, you know, medicine is increasingly a team sport. And I've heard from patients that they're worried about jeopardizing their relationship with their current provider by asking for a second opinion. And really, I want to say that I think doctors are increasingly collaborative and professionally committed to working together. And I also encourage patients to seek a second opinion. Sometimes I'm helping them find a second opinion, or a provider to give a second opinion. Sometimes I'm the second opinion, but I think anything that can improve the accuracy and the management of your care, you should really advocate for, and don't be concerned about hurting anyone's feelings or jeopardizing any relationships. Second opinions are very healthy.
Thank you. Manish, I'll stick with you for this question, but are there certain patients who may benefit from expanding a workup to include genetics, even if CKD has been attributed to diabetes or hypertension?
Yeah, so I think there are, and I think the literature supports this, that a lot of the patients who are called, diabetic kidney disease or hypertensive kidney disease, upon further evaluation, will have something else, right? So diabetes and high blood pressure are very common in most societies, and there's nothing to prevent you from having something else underlying your kidney disease, and you just happen to also have diabetes or high blood pressure. And the other thing is, high blood pressure is part and parcel of chronic kidney disease. Sometimes it's the result of chronic kidney disease, and sometimes it's the cause of chronic kidney disease. So there are certain things, too many for me to name now, that increase the probability of diabetic kidney disease or hypertensive kidney disease, the duration that you've had it, the severity, other sorts of corresponding findings on physical exam, for example, in diabetes, looking for disease in the eyes, and the blood vessels of the eyes can often predict the blood vessel disease in the kidneys. But if something doesn't, if someone's had high blood pressure, for just a few years or so, and they've got significant chronic kidney disease, it's very unlikely that the high blood pressure was the cause of that chronic kidney disease. It's probably more of a symptom of the chronic kidney disease, and it deserves a deeper look, just as one example.
Thanks, Manish. Delphine, kind of on similar lines regarding transplant. We found some of the patients that have, in our databases, being an unknown cause, had a higher rate of lost transplant or lost several transplants. We in this process talked to several patients who got a transplant, never really knew what the cause was, or it was attributed to, Manish said, high blood pressure, lost that transplant and found out it was a rare disease. In that kind of thinking through that, what patients that are post-transplant never got a diagnosis, should they be looking to try to identify this cause?
Yeah, I think yes and no. I mean, yes, whenever there is uncertainty of the cause of kidney disease, I think it's important to delve in further. I do think most of the time when kidney disease is attributed to either diabetes or hypertension, that is the cause most of the time. However, when there are a few clinical clues that kind of point away from diabetes or hypertension, I think that's when the genetic testing can be helpful, including after transplant, or including when you're on dialysis and waiting for a transplant, for a couple reasons. I think one, if it's pre-transplant, knowing the cause of your kidney disease, if it's different than what was attributed, may actually change the type of transplant therapy that your transplant providers will give you for optimal longevity of that kidney transplant. I think additionally, it's really important to inform potential living donors. If you have a genetic cause of your kidney disease, it's very possible that someone else in your family who's interested in donating may also have that kidney disease that is asymptomatic. And so again, I think it is important, if there's any hint that there may be something else going on, to look into the genetics of kidney disease.
Thank you very much, Delphine. Question from our audience, and Delphine, Manish, hopefully one of you are willing to take this one, but I would appreciate it. But can you just give more information on APOL1 testing? Kind of what is the APOL1 gene, and what does it do, and who should be tested?
I'm happy to start, and please jump in, Delphine. So the APOL1 gene turns out that is mutations in the APOL1 gene leading to a high-risk sort of genotype or high-risk genetic signature account for a large proportion of chronic kidney disease and end-stage kidney disease among the African American population. So this was a discovery about 10, 11 years ago. Actually, it was at my former institution at the Beth Israel Deaconess Medical Center in Boston, that having a high-risk genotype in this gene among African American patients really increased the risk of progressing to end-stage kidney disease and requiring dialysis or transplant. So the testing for these high-risk mutations is starting to become more common in the clinic among this population. It's still an ongoing process when the benefits outweigh the risks, et cetera, but it's been successfully used in transplantation, for example, to make sure not to, allow a living donor donate a kidney in the setting of having the high-risk APOL1 genotype, because that would actually likely do harm to that donor. So it's coming of age in nephrology. Delphine, if you have any other thoughts on the APOL1 alleles.
No, I completely agree. I think we are learning more and more about the APOL1 high-risk phenotype. As a reminder, you need 2 abnormal genes to be a high-risk individual, not just one abnormal gene at the APOL1 locus in your chromosome. And so it is more common among individuals of African ancestry. So it's important to consider not just African American individuals, but individuals with African ancestry. And I think in particular, it's becoming more common or more available when being evaluated for transplant, just because of the implications. I think the rest, we are still trying to understand what types of therapies we might have available in the pre-transplant world. And so a lot of that, there's just ongoing research, both at the NIH and in a variety of centers of excellence across the country. So more to come.
Thank you very much. One last quick question to Jack, and then we'll give everyone a chance for some final thoughts. But Jack, if you find out you have a genetic rare disease, what's your advice for bringing this up to family members?
Well, one of the times that this may be easiest is potentially around Thanksgiving, quite honestly. That is a kind of a nationwide rare disease education time to be able to bring this up. Also, if you have, concern for others that may have similar symptoms or something like this, you can approach them that, this, we found this out, for myself or for one of my family members, and it's very important for you if you want to be able to get testing and so forth. And particularly with Fabry, the mutations are oftentimes family specific. So if you're able to share that information, that makes testing that much easier, particularly for females. So yeah, these are very important questions and very important topics to approach.
Thanks, Jack. Great idea for the Thanksgiving conversation. Well, I want to thank everyone for the questions today. I want to thank you for joining us and participating. But before we leave, I wanted to give each of our panelists a chance to give their final thoughts. And Manish, I'll start with you.
No, just, briefly, thanks for the invitation and the opportunity to, give my thoughts on this extremely important topic. And I think it was a really lovely discussion today. A lot of good points were raised. And I would just say to the patients out there, be your own advocate and, make sure you're getting the answers you want and need to get. Make sure you're an active participant in your own healthcare, and taking part in seminars such as this is a great way. There are numerous resources that American Kidney Fund and other sorts of patient advocacy groups have online. So keep learning and keep being your own advocate. And it's really the way medicine is practiced these days. So thanks again for the opportunity.
Thanks, Manish. And Jack, and if there's any resources from Fabry Support and Information Group you want to share as well, so people can try to find your organization, please feel free to share that, but I'll turn final thoughts to you.
Yes, thank you. So to get information, our organization is fabry.org, very simple and easy to find, fortunately. And there are many programs that are available for individuals, as well as opportunities to meet up virtually or to be pen pals or so forth with others that may be going through very similar situation. And there are many other organizations out there, of course, for just rare diseases in general, as well as specific conditions. So there are lots of resources, and we encourage you to take advantage of those for your own benefit.
Thanks, Jack. And Delphine, we'll leave you with the final thought.
Great, thank you. I just want to echo the idea that knowledge is power. Please be your own advocate. Please ask questions, come prepared, jot down all of your questions for your provider, and do not hesitate to ask until you feel comfortable with the answers. I think sometimes it can be scary to ask a lot of questions. It can be unnerving to get some of those results, but those results and a better understanding what's causing your kidney disease, and if you are at risk for kidney disease in general, I think are super important for your health moving forward. So please never hesitate to ask.
Thanks, Delphine. And a huge thanks again to all of our panelists and for all of you who joined us today, our first session just about in the books. I want to give a special thanks once again to our sponsors of the Unknown Causes of Kidney Disease project. We'll bring that sponsor slide back on the screen again. Thank you very much. Once we conclude this session today, you will see a link for a quick survey in green below the video screen. It would really help us immensely if you could take a few minutes to fill it out, tell us how we did today, and your feedback will be very useful as we plan for future sessions. Our next session, hypertension, diabetes, and kidney disease, understanding the connection, will begin at 12:30 p.m. Eastern, 9:30 a.m. Pacific time, and we will see you then for that great session. It'll feature a cardiologist, a nephrologist, and endocrinologist, and how that healthcare team works together to keep your kidneys healthy. So please join us for that one. If you're not already, follow us on Facebook, on Twitter, and you can get more information at kidneyfund.org. Thanks again for your time today.